So welcome everyone. What I want to talk to you today about really is the overlap between the pure high energy physics research that we do and medicine, and in particular cancer treatment. As Carsten mentioned earlier, there is a strong connection between the machinery that we have developed for research and the machinery that you use for treatment. There's a small joke in the title, but we'll come to that as we go along. Now, like any good physicist, I should probably start off talking to you about things that I don't understand, so in this case, medicine. When we look at how cancer evolves, really there are two cellular processes that we're most interested in. The first is how cells divide. And this is a process called mitosis in the cells in our body. And I'm hoping that most of you have seen pictures like this of the DNA strands in a nucleus that will unwrap themselves and then separate themselves out into their pairs and then form new pairs, and two new nuclei will form. And then that will gain a sheath, and then the cell itself will divide. And in that way, cells are self-sustaining. The other process that I want to introduce is really at the other end of a cell's lifespan. So one of the fascinating things for me is that each different cell in your body has a different lifespan depending upon the tasks that it wants to accomplish. And some of them are very short-lived, so white blood cells can live less than the day, particularly if they're trying to help your body fight off infection. Stomach lining, skin cells, they're all things that get sloughed off on a regular basis. Then you go all the way down to brain cells, neurons, which are supposed to last your entire lifetime. It's why brain injury is so hard to recover from, because nerve cells in the brain do not regenerate. But alongside having a pre-programmed lifespan, cells also know to self-destruct, and that's a process called apoptosis. If, as they undergo replication, they realize that they've picked up too many errors, a healthy cell will actually know, uh-oh, there's something that's gone wrong, and self-destruct in this really ordered, clean fashion. They'll actually package themselves up and hand parts of themselves off to neighboring cells. Now, what happens with cancer is both of those processes go wrong. But you need a lot of other errors to accumulate in the cell for cancer to develop. So within each cell, you have genes that will regulate how fast and how often each one of those cells will replicate. There are genes called oncogenes. In fact, in a healthy cell, they're called proto-oncogenes, which are telling a cell, divide, divide. On the other hand, you have tumor suppressor genes, which are trying to damp down that process, so to keep the two in regulation and make sure that a healthy cell spends something like 1/10 of its lifespan dividing and replicating, and the rest of the time actually doing what it's supposed to do. So now let's assume that we get problems with that process. If the oncogene gets an error, then that cell division can then go into overdrive. That signal to keep dividing can go into overdrive. Now in a healthy cell, that would be moderated by the tumor suppressor gene. But now let's assume that you get an error in the tumor suppressor gene, so that brake on that replication mechanism is no longer there. And now the cell can go into this overdriven replication. But in a healthy cell, apoptosis should kick in at that point and say, okay, time to self-destruct, we've got too many errors. Now, if the apoptosis signaling pathway gets blocked, now you have a cell that is undergoing uncontrolled replication that doesn't know to self-destruct, and it's become immortal. And that's the basis of cancer. Now that's how we get to cancer. What I'm more interested in is how we treat it. And the three main ways that we treat cancer are to remove it with surgery, to irradiate it with radiotherapy, or attack it chemically with chemotherapy. Now the funny thing is that when you think about somebody who's undergoing cancer treatment, what you normally think of is them losing their hair, which is actually a side effect of the chemotherapy, because the chemotherapy is attacking all of the cells that are dividing in the body. And because your hair is growing all the time, that's why your hair falls out. Actually, when it comes to the main contributions to the cures, it's at the bottom of the list of those three. The most important is surgery. I remember speaking to an oncologist once, and they said, if you want to cure cancer, become a surgeon, because if you can excise it, if you can remove that tumour surgically, that's the best way. But the next best option is radiotherapy. The principle behind radiotherapy is actually similar to chemotherapy, and it's why I talked about cell mitosis at the start. If you can take a cell that is undergoing that replication, it's in the process of division, as its DNA strands start to separate out, it becomes vulnerable. If you can break those DNA strands, when the cell is in the process of mitosis, the cell starts to fall apart and it can't replicate anymore. And the more breaks that we do to that DNA double helix, the more damage we do to the cell and the more likely it is to die. If we can target that treatment, then that means that the cell killing, or the killing of the cells that we want to kill, so the cancer, becomes more effective. And this is where radiotherapy comes in. So let's imagine that we're putting a beam of X-rays through the body. So radiotherapy is a beam of high-energy X-rays, and those X-rays will pass all the way through the body, and they do more damage a few centimetres into the body. So if you've just got one beam, imagine you've got a tumour that's right in the middle of the body, you do most of your damage a few centimetres in, and then you do less and less as the X-rays pass through the body. Now that's okay so long as the tumour is close to the skin, but it's not so good for tumours that are deeper into the body. So let's add in another beam of X-rays. And now by making them overlap, we can enhance the damage that we do at specific locations. So we know where the tumour is, that's where we want to do most of the damage. So if we bring in another beam, now we're doing more damage at the tumour than we are anywhere else in the body. And really that's the principle behind modern X-ray radiotherapy, is actually you bring in X-rays from all the way around the body and you add up to do most of the damage in the tumour. Now these are treatment plans. You've got two different treatment plans here. The one on the right is quite simple. That's for prostate. So prostate is in the middle of the pelvis. So the top view is an X-ray slice through the middle of the pelvis about there. And you can see you've got 1, 2, and then 3, one posterior beam coming in, and you're trying to irradiate the area that you see in green. And you see, because you get an enhanced dose in that region, you get more damage done in that area than in the rest of the body. The next one on the left-hand side, that's non-small cell lung cancer. Now this is more complex. Rather than having 3 fixed beams, you've actually got a series of beams. You've chosen the direction that those X-rays are going to come in. And inside that green contour, that's the area that you're trying to irradiate. And you see that you get more dose delivered to that region than you do to anywhere else in the body. The way that you deliver this treatment is with a radiotherapy gantry. And that will actually produce an X-ray beam, and this whole assembly actually rotates. Let's restart that. The whole gantry will rotate around the body, and you can see you've got a beam that's then shaped to the size of the tumour that's coming in from 360 degrees. And that's how you try and minimize the damage that you do to healthy tissue and deliver as much dose as possible to the tumour itself. The problem is, as anybody who has actually had an X-ray will know, X-rays do not stop in the body. Quick straw poll, does anybody know what's wrong with that patient? Any guesses? Shout out. Anybody? Say again? No, he's got no head. Or arms or legs, apparently. Why they took the X-ray, I don't know. But anyway, the point is that in order to get an X-ray image, you need the X-rays to pass through the body. They will get absorbed in higher density parts of the body, so your bones, and pass through things that are soft tissue. What we really want when we're delivering cancer treatment is for the energy, for the dose, for the damage to happen in the region where we most want it. We want all of that dose to be deposited in the tumour. And this is where proton therapy comes in. If you take a look at the amount of dose, which means the amount of energy deposited, so the amount of damage that you're doing to cells in the body, that big blue curve called photons, that tells you what damage you get from X-rays. So you get this peak that's a few centimetres in and then it drops off exponentially. What you get with protons is almost the opposite behaviour. You get this big fat proton that's much heavier than all of the electrons that it's interacting of all of these DNA strands of all of these cells, and it's going bump, 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 bump. It's just slowing down little by little as it's going through the body. As it slows down, it deposits more energy, which means it gets slow, which means it slows down, which means it deposits more energy, which means it interacts more often, which means it slows down, and it comes to this screeching halt right at the end of its path and dumps most of its energy at the end. And that peak is actually called the Brage Peak, named after Lawrence Bragg, who discovered it. The advantage of that is twofold. First of all, it means we deliver less dose on the way in, but also it means that we've got this very hard stop. So we've got a finite range to that proton beam. So if we know what the energy is of the protons that are coming in, we know exactly how far they're going to travel. And we use this for radiotherapy. So if we take our beam of protons and we adjust the energy, then we know exactly how far they're going to travel in the body. What you've got here is a block of a material called a scintillator, which means that it glows whenever you deposit energy into it. And you can see you've got this really hard boundary. As we're changing the energy of this beam, we're just scanning the energy of this proton beam as it moves backwards and forwards. You get no dose deposition beyond the end of that proton beam. The other thing you can see from there is the beam is quite small. With X-ray radiotherapy, you end up with beams that are tens of centimetres across. Here, it's no more than about a centimetre across. And with that much smaller beam, it means the way that you treat is different from how you do it with X-ray radiotherapy. What you actually do is scan these little pencil beams across the tumour. So you start off with the highest energy, and you choose your highest energy beam and scan it in position across the tumour. And then you change the energy. Now that means that the beam isn't going to go so far. And then you scan another layer, and you change the energy, and that means the beam doesn't go so far, and then you scan it again. And in that way, you can scan the entire volume of the tumour. Now anything that's behind the tumour doesn't get any dose at all. So in theory, that means that you can actually irradiate a tumour that's very close to a sensitive structure, which you absolutely do not want to damage, which otherwise with conventional radiotherapy you couldn't, because the X-rays are going to pass right the way through. Now if you look at a treatment plan, here's a simple example. This is medulloblastoma. Now medulloblastoma grows in the base of the skull. But the problem with medulloblastoma is that it metastasizes, it spreads, and it spreads out into the cerebrospinal fluid. And the cerebrospinal fluid encompasses the whole brain and the spinal column. So that means that when you irradiate medulloblastoma, you have to deliver dose to the whole cerebrospinal volume. Now, if you've just got a single beam of X-rays, and in this case, it's a treatment plan for a single beam that's coming in from the back to irradiate the spinal column, X-rays are going to pass right the way through the body. Now, if that's a young child, that means you're irradiating not just the spinal column, but heart, lungs, liver, all of the organs of that young child. That's what you see down the bottom. So you can see when you deliver the dose to the spinal cord, you get a not insignificant amount of dose to the rest of the bodily organs. With protons, because they're going to stop in that cerebrospinal volume, you minimize the amount of dose that you're getting to the rest of the body. Now that's just with one single beam direction, which is not how we tend to treat. But with multiple directions, you still end up with the same effect. So this is with the same non-small cell lung cancer. On the left is the X-ray radiotherapy. So again, within that green line, that's the region that you're trying to treat. And you can see, compare it to the proton therapy on the right, you get a higher dose delivered to the area that you want to treat and less to the surrounding tissue. And that's why we choose to treat with protons. Now, what has all of that got to do with the Large Hadron Collider? So here's a quick refresher. This is what the entire complex at CERN looks like. As Carsten said at the start, the Large Hadron Collider is not a particle accelerator all on its own. It's built up of an entire chain, all designed to go from slow to faster to faster to fast to the highest energy that we've ever been able to produce. Now you start off with a linear accelerator, and at CERN that's now called LINAC 4. That will take the protons from hydrogen gas from a standing start and then accelerate them up into the smallest of our circular accelerator called the proton synchrotron. But now we need to get bigger. The next stage is called the superproton synchrotron, and that takes energy from the proton synchrotron and accelerates them up even to higher energy. And because the energy is higher, the size is getting bigger. And ultimately, we end up with the Large Hadron Collider. You can see as you look down all of those accelerator tunnels that they get bigger and bigger and longer and longer and longer. What you can't do is take that kind of machinery and use that straight away for proton therapy treatment. If any of you have heard of Anatoly Bugorsky, he's a great example for why researchers shouldn't treat cancer. He was working at a research accelerator in Russia in the 1970s and got shot through the face by a proton beam. What he was doing was trying to maintain the accelerator. He was repairing some of the detector systems, and the safety systems failed, and that meant that as he was in the process of fixing it, the beam actually got let go and shot right through his head. He actually survived, and other than the periodic severe epilepsy, he was fine. But judging by the angle of the beam, I'm pretty sure that his job was to align the beam, and he was doing it by eye, because that's where he got hit. But the basis of all of the technology that we use for modern proton beam therapy has come out of those research machines. This is the accelerator complex at the Heidelberg Ion Therapy Center. This is a proton and carbon ion treatment center in Germany. Now, on the one hand, this is a purely clinical center, so there is a little bit of research done, but the purpose of the particle accelerators that are being built here is for medical treatment, not for research. But if you start to look at the components from which we built this facility, you see some real similarities. So at the start, you've got gases, bottles of gas, you've got an ion source. Now, in this case, not only have we got hydrogen, we've also got helium, and we've got carbon dioxide, so we can produce beams of carbon and oxygen. And then you have a linear accelerator, so you have a way of taking the ions out of that ion source and accelerating them up from a standing start. And now you need an accelerator ring in order to get them up to the energy that you want to. Remember that I said in order to get the beam to travel a specific distance, they need to be a specific energy so that you know the range that they're going to travel. And once you've got the beam up to the right energy, then you need to transport it somewhere. You need to deliver it. And you have beam lines with dipole bending magnets and quadrupole focusing magnets that are exactly like the structures that we have in the research machines. The technology is exactly the same, except instead of colliding those beams into one another and seeing what comes out, trying to produce new particles, discover the Higgs boson, now we actually want to use it for treatment. And this is where the real difference is set in. So our target in this case is a tumour, and it's in the body of a living, breathing patient. At least we hope they're living and breathing, otherwise we wouldn't be doing the treatment. This is what a fixed beamline treatment room looks like. So you have one beam, and that's what you see on the left is the nozzle that delivers the beam to the patient, and the patient is mounted on a robotic couch and can move around. But we also, just like X-rays, want to deliver that beam from 360 degrees. And this is kind of the hard part. This is where gantries come in. What a gantry is it's that particle accelerator, but on a large moving structure that then rotates around the patient. And I'll come back and show you some more pictures of that in a moment. But at the end of that gantry, we have another treatment room, and we have another nozzle that then delivers that beam to the patient. Now, the hard part of building particle accelerators for proton and ion therapy is not the accelerator. It's getting the beam to the patient. At Heidelberg, they actually have the largest gantry in the world. It is 22 meters long, 13 meters in diameter, so the diameter of that is almost 5 stories tall, so at least twice the height of this lecture theatre. And all of that structure weighs 600 tons and is the length of an articulated lorry and has to rotate around the patient with sub-millimeter precision in order that the beam goes in the right direction. So that large detector that Carsten showed you right at the start, the compact muon solenoid, this is about the same size, but this has to deliver beams of protons to a living person. If you look at that gantry up close, you'll see that you have exactly the same components as you do in the rest of the beamline. So you've got dipole magnets to bend the beam, quadrupole magnets for focusing the beam, all designed to steer the beam in the right direction and get it to the patient. And to give you a sense of how big it is, this is the Heidelberg gantry, and underneath there is a person for scale, and because he's German, he's bigger than average. So you begin to get an idea of how large that structure is. So we, as accelerator physicists, we deliver the service, and then it becomes the job of the engineers and the clinicians to do the hard part. Now, inside the treatment room, you really don't want to see any of that technology, and if you're like me and you're fascinated by it, and then you really want to take the walls down and see what it's made from. But this is what a modern treatment room looks like. In the room, you'll have a monitor that shows you where the patient is and what the position of the gantry is. You have the gantry itself, and you have to imagine that that gantry and the scanning nozzle, all of that will rotate through 360 degrees, so you can deliver the beam from any angle. In the room, you have a little alcove. Now, what that alcove is for is because the radiographers will come in and align the patient and then image the patient with x-rays to make sure that they're in exactly the right position. Because the precision of that treatment means you need to know just as well where the patient is sitting and where the tumour is so that you can radiate it correctly. And so they'll stand behind that alcove because then that has radiation shielding in it, so they don't get irradiated by the x-ray beam. There are hand pendants for controlling the position of the treatment table, which is where the patient sits. And then you also have a laser alignment system that allows you to see exactly where the couch and where the patient has been aligned. Now, in the UK, we actually have 2 new proton therapy centres being built by the NHS. And one of them is not far from here in Manchester, and the other one is in London. It's the London one that I work on. These deliver treatment with protons with these 360-degree scanning gantries. The entire project to build these 2 centres cost £250 million to the NHS, and it was the single largest equipment project that the NHS has ever done, so there was a certain amount of pressure on us to get it right. But the Christie actually started building in 2015, and they treated their first patients last year. UCLH is a little bit slower because it's a much bigger building that's right in the centre of a very densely populated city, and that's going to open next year. And each of those centres has 3 treatment rooms, and the plan is to treat about 1,500 patients split between those 2 centres. Now, in the NHS, there are actually 3 centres, not 2, and the third is actually something of a first. It's not that far from here. In fact, if you stand on the edge of the Mersey and look over into the Wirral, that's where it is. It's the Clatterbridge Cancer Centre. And Clatterbridge was built in 1989, and it's the world's first hospital-based proton beam therapy centre. But it's much smaller, so at Clatterbridge, all they treat is eye tumours. Remember I said that the range of those protons depends directly on the energy. So if you don't have much energy, then you can't go too far. So they have a beam that will go just over 3 centimetres, so just enough to go to the back of the eye. Now, with an eye treatment, it means it's quite a bit simpler. You don't need this moving couch. You can sit the patient and you align the patient and fix their head, and then the beam comes in from the front and irradiates the tumour at the back. And what you can see there is pictures of Andrei Kasparek, who's the head of medical physics there, just setting up 2 patients ready for treatment. In the bottom left, that's what the treatment room looks like. So the beam comes out of that single nozzle, just comes in a single direction, and the patient sits in that couch just in front of the beam. For a full-sized facility, this is what it looks like. This is at University College Hospital. So you have a compact particle accelerator. It's smaller than Heidelberg because it doesn't need to accelerate all of those different ions. It's just accelerating protons. It's called a cyclotron. But you have the same beam transport line. You need to take that beam out of the accelerator and then deliver it to the treatment rooms. There are 4 treatment rooms, and for each one of those treatment rooms, you have a gantry. Now, the 4th room is actually the last one to be installed, which is why it's grayed out there. This is what the entire facility looks like. So you have the cyclotron, and from the cyclotron, you produce protons that you're going to deliver to treatment. In front of that, you have what are called your energy selection systems, and the energy selection system makes sure that the energy that you're getting to the patient is exactly right. Once you've selected that energy, then those protons come down the beamline and now need to get directed to the treatment rooms. The beam delivery system will choose which one of those treatment rooms that you're delivering the beam to for treatment. That then comes into the gantry, and each one of those gantries can rotate around the patients from 360 degrees. But because you're delivering radiotherapy, all of that has to be set in concrete, so everything is shielded in concrete. And at University College Hospital, that's all about 4 or 5 stories below the ground. And on top of that, you have an entire building. That's where the rest of the hospital sits. So all of that is contained in one building. And that's really where we are today. We're just at the point where you can see, if you go and visit University College Hospital, you'll see that that building has come above ground. And we're at an exciting stage because Christie has just treated their first few patients, and University College Hospital is just about to start testing the particle accelerator for treatment. And at that point, I'll leave you. Thank you.